Welcome to today's pharmacology quiz on selective serotonin reuptake inhibitors, or SSRIs. In this video, we'll explore key concepts about SSRIs, the drugs used to manage conditions such as depression, anxiety disorders, and obsessive-compulsive disorder. This quiz features 10 multiple-choice, scenario-based questions designed to test your understanding. Each question includes 5 options, followed by the correct answer and a clear explanation. There's also a companion video that provides a detailed review of SSRIs, and you'll find its link in the description below. So, let's get right into it. Question 1. Mr. Henderson, a 45-year-old male with major depressive disorder, has been taking fluoxetine for 4 weeks with partial improvement. He reports persistent insomnia, restlessness, and mild tremors. His doctor considers switching therapy. Which of the following mechanistic properties best explains the side effects he is experiencing due to increased serotonin activity in certain brain regions? Option A. Increased 5-HT1A receptor stimulation in the raphe nuclei. Option B. Blockade of 5-HT2A receptors in cortical neurons. Option C. Stimulation of 5-HT2 receptors in spinal motor neurons. Option D. Enhanced inhibition of norepinephrine reuptake. Option E. Increased dopaminergic transmission in the mesolimbic pathway. The correct answer is option A. Increased 5-HT1A receptor stimulation in the raphe nuclei. The explanation is that excessive stimulation of 5-HT1A receptors in the raphe nuclei and other serotonergic areas can produce symptoms such as restlessness, tremors, and insomnia. These effects are related to heightened serotonergic tone during SSRI treatment, particularly in the early weeks. As fluoxetine increases serotonin levels, overstimulation of certain receptors can cause these activation-type side effects before tolerance develops. The other options do not explain these specific serotonergic activation symptoms. Question 2. Mrs. Coleman, a 32-year-old woman, is prescribed sertraline for postpartum depression. She is breastfeeding a 3-month-old infant. She expresses concern about potential harm to her baby. Which of the following SSRIs is considered most appropriate during lactation, based on its low breast milk concentration and safety profile? Option A. Paroxetine. Option B. Citalopram. Option C. Fluoxetine. Option D. Escitalopram. Option E. Fluvoxamine. The correct answer is option A. Paroxetine. The explanation is that paroxetine is preferred in breastfeeding because it has minimal transfer into breast milk and a favorable safety record for infants. Compared to other SSRIs, it results in negligible plasma concentrations in the nursing child. Fluoxetine and citalopram, by contrast, have higher milk-to-plasma ratios and longer half-lives, increasing the risk of accumulation. Therefore, paroxetine is often recommended as a first-line SSRI during lactation when antidepressant therapy is necessary. Question 3. Mr. Bradley, a 60-year-old with chronic liver disease and generalized anxiety disorder, is started on an SSRI. His physician wishes to minimize the risk of drug accumulation due to impaired hepatic metabolism. Which SSRI should be avoided in this patient because of its long half-life? Option A. Fluoxetine. Option B. Sertraline. Option C. Paroxetine. Option D. Escitalopram. Option E. Fluvoxamine. The correct answer is option A. Fluoxetine. The explanation is that fluoxetine has an exceptionally long half-life, with its active metabolite norfluoxetine extending elimination to several days or even weeks. In patients with hepatic impairment, this leads to significant drug accumulation and prolonged adverse effects. Sertraline and escitalopram, on the other hand, have shorter half-lives and are better tolerated in liver disease when used at reduced doses. Therefore, fluoxetine should be avoided in patients with chronic hepatic impairment. Question 4. Miss Andrews, a 28-year-old woman treated with paroxetine for panic disorder, complains of fatigue, sexual dysfunction, and weight gain. Her psychiatrist considers switching to another SSRI. Which of the following statements regarding SSRIs and sexual adverse effects is least accurate? Option A, paroxetine has a higher incidence of sexual dysfunction. Option B, fluoxetine and sertraline often cause delayed orgasm. Option C, citalopram has the lowest risk of sexual side effects. Option D, sexual dysfunction is mediated through increased serotonin tone. Option E, SSRIs improve sexual function by increasing dopamine transmission. The correct answer is option E, SSRIs improve sexual function by increasing dopamine transmission. The explanation is that SSRIs typically reduce sexual function rather than improve it, mainly due to increased serotonin activity inhibiting dopamine and nitric oxide pathways linked to sexual response. These effects manifest as reduced libido, delayed orgasm, or anorgasmia. Paroxetine is most often associated with these adverse effects, while citalopram and escitalopram are somewhat less likely to cause them. Therefore, stating that SSRIs improve sexual function is inaccurate. Question 5. Mr. Dawson, aged 52, is admitted with hyponatremia, Na equals 124 millimoles per liter, normal 135 to 145, and confusion. He has been on citalopram for 3 months for depression. His other medications include hydrochlorothiazide and lisinopril. Which of the following mechanisms most likely explains this adverse effect? Option A, inhibition of renal sodium reabsorption at distal tubule. Option B, SSRI-induced SIAD causing increased water retention. Option C, stimulation of aldosterone secretion. Option D, blockade of vasopressin V2 receptors. Option E, inhibition of renin secretion. The correct answer is option B, SSRI-induced SIAD causing increased water retention. The explanation is that SSRIs such as citalopram can trigger the syndrome of inappropriate antidiuretic hormone secretion, or SAADH, leading to dilutional hyponatremia. This occurs when excess ADH promotes water reabsorption in the collecting ducts, reducing serum sodium concentration. The risk is particularly high in older adults and those on diuretics like hydrochlorothiazide. Recognition of this mechanism is important because it necessitates dose adjustment or discontinuation of the SSRI to prevent further electrolyte imbalance. Question 6. Mrs. Jenkins, 70 years old, is on escitalopram for depression and omeprazole for reflux. After 6 weeks, she presents with dizziness and prolonged QT interval on ECG. Which of the following SSRIs is least likely to cause QT prolongation and may be a safer alternative? Option A, sertraline. Option B, citalopram. Option C, escitalopram. Option D, fluoxetine. Option E, paroxetine. The correct answer is option A, sertraline. The explanation is that sertraline has the lowest risk of QT prolongation among the SSRIs, making it the preferred choice in patients with cardiac risk factors or concurrent QT prolonging drugs. Citalopram and escitalopram are known to cause dose-dependent QT interval prolongation, especially in older adults or those on CYP2C19 inhibitors such as omeprazole. Fluoxetine and paroxetine have moderate risk but are still less ideal in elderly patients with polypharmacy. Therefore, switching to sertraline would provide a safer cardiac profile for Mrs. Jenkins. Question 7. Mr. Ramirez, a 38-year-old patient with OCD, is taking fluvoxamine. His physician plans to add clozapine for treatment-resistant schizophrenia. Which of the following interactions is most clinically significant? Option A, fluvoxamine inhibits CYP1A2, increasing clozapine plasma levels. Option B, clozapine induces CYP2C19, decreasing fluvoxamine efficacy. Option C, fluvoxamine increases dopamine blockade in striatal neurons. Option D, clozapine enhances serotonin release in the limbic system. Option E, fluvoxamine accelerates hepatic clearance of clozapine. The correct answer is option A, fluvoxamine inhibits CYP1A2, increasing clozapine plasma levels. The explanation is that fluvoxamine is a potent inhibitor of the cytochrome P451A2 enzyme, which is primarily responsible for metabolizing clozapine. This interaction can dramatically elevate clozapine concentrations, increasing the risk of seizures, sedation, and agranulocytosis. Close monitoring or avoidance of this combination is therefore recommended. The other options describe mechanisms or effects not relevant to the significant pharmacokinetic interaction between these two drugs. Question 8. Mrs. Harris, a 50-year-old woman on venlafaxine for depression, is considering switching to fluoxetine due to cost. The physician cautions her about the risk of serotonin syndrome if the switch is not managed correctly. Which of the following steps is most appropriate when transitioning between these agents? Option A. Overlap fluoxetine and venlafaxine for 1 week. Option B. Stop venlafaxine and start fluoxetine immediately. Option C. Taper venlafaxine, allow washout, then start fluoxetine. Option D. Add fluoxetine while maintaining half-dose venlafaxine. Option E. Reduce venlafaxine slowly while adding fluoxetine the next day. The correct answer is option C. Taper venlafaxine, allow washout, then start fluoxetine. The explanation is that switching between serotonergic antidepressants like venlafaxine and fluoxetine requires a cautious taper and a short washout to prevent serotonin syndrome. Overlapping therapy or starting fluoxetine too soon after venlafaxine increases the risk of excessive serotonergic stimulation, leading to dangerous symptoms such as hyperthermia and agitation. Allowing the body to clear venlafaxine before introducing fluoxetine ensures safer serotonin rebalancing. Hence, a taper and washout strategy is the appropriate approach. Question 9. Mr. Johnson, a 44-year-old man with depression, migraine, and chronic pain, is being treated with amitriptyline. He reports intolerable drowsiness, so the physician plans to change to an SSRI. Which of the following SSRIs would be least suitable due to a high risk of drug interactions via CYP inhibition? Option A. Fluvoxamine. Option B. Sertraline. Option C. Escitalopram. Option D. Citalopram. Option E. Paroxetine. The correct answer is option A. Fluvoxamine. The explanation is that fluvoxamine is a strong inhibitor of multiple CYP enzymes, including CYP1A2, CYP2C19, and CYP3A4. This leads to significant drug interactions with medications like tricyclic antidepressants, benzodiazepines, and theophylline. In contrast, sertraline, escitalopram, and citalopram have minimal CYP inhibition and are safer alternatives. Because amitriptyline is metabolized by these hepatic enzymes, fluvoxamine would be the least suitable SSRI in this scenario. Question 10. Mr. Sanders, a 35-year-old patient with major depression, is on fluoxetine. He develops agitation, hyperreflexia, diaphoresis, and tremor after starting linezolid for pneumonia. Which of the following statements regarding serotonin syndrome is false? Option A. It may result from combining SSRIs with MAO inhibitors. Option B. Symptoms include hyperthermia and neuromuscular excitation. Option C. Cyproheptadine is a serotonin receptor antagonist used in management. Option D. Benzodiazepines can be used for sedation and muscle relaxation. Option E. Beta blockers are the treatment of choice to reverse serotonin excess. The correct answer is option E. Beta blockers are the treatment of choice to reverse serotonin excess. The explanation is that beta blockers are not used to reverse serotonin toxicity and can actually worsen hypotension or bradycardia in severe cases. The cornerstone of management involves discontinuing serotonergic agents, providing supportive care, and using benzodiazepines for agitation or muscle rigidity. In moderate to severe cases, cyproheptadine, a serotonin antagonist, may be administered. Therefore, stating that beta blockers are the treatment of choice is false. Conclusion. That wraps up our revision on selective serotonin reuptake inhibitors, or SSRIs. I hope this quiz has helped reinforce your understanding of the key pharmacological concepts and clinical uses of these important antidepressant agents. For further reading, I recommend exploring Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF, to deepen your knowledge of SSRIs and related drug classes. These resources provide clear, evidence-based explanations that are invaluable for exam preparation and clinical practice. All guideline references mentioned in this video specifically follow the BNF, so continue studying diligently and keep building your pharmacology expertise with confidence.